I think just to follow on your comment, the person who really made cavernous sinus surgery easy is Vinco, and I follow his footsteps. He actually said, uh, it is now no man's land, but one day it's going to be everybody's playground. I quote him, and he is very true. This is the pioneering thinking that he had. But like you said earlier, we like to call our Little Rock place a big rock. This is our institute. This is inspired by a vision of Professor Al-Mefti and Professor Yazergil. It has the Yazergil Neurosurgical Research Center. It also has the Usama Al-Mefti laboratory. It's a whole unit, like a small village for neurosurgical care. We've all worked hard, and I was inspired by their input. This is the place where we do our courses now. This is our auditorium, which is connected to our operating room with 3D capabilities that we do our courses on. Vinco and Professor Ernest and everybody has been here before, Professor Toure. This is our laboratory. Dr. Al-Mefti's name is on it. It's a state-of-art place to teach young and young in mind microsurgery. And also, as we all remember, our dear beloved Evandro, who just passed away. Evandro has been so supportive to my trip on aneurysms and in the cavernous sinus as well. And this is a conference room which we replicated that we used in our previous setup and put his name on it because he's been to it so many times giving lectures and courses. So uh, now coming to dealing with the basilar aneurysms, and as was mentioned before, that a lot of aneurysms still benefit best from microsurgical intervention. I would start by saying, mastery is really not a function of genius or talent. It's a function of time, intense focus applied to a particular field of knowledge. And it is well best represented by Professor Yazagil's lifetime and how he achieved things. And these are kind of echoing what I used to hear from him all the time. Now, there's another element. Those who have really mastered something, you noticed, and I have a lot of teachers who are pioneers, and a lot of them are distinguished guests here, have a strong inner guiding system, I would call it, not to follow the path that others have followed. And because we are conformist creatures, most of us opt for this conventional route because it's easier. So that creates a trend to follow, and these are the popular trends. But these can cause pressure, forcing us to conform. And in that case, we end up doing wrong things to some patients because when you follow the popular, it doesn't apply to every case, and then it becomes a problem. And trying to fit into a conventional mold would only lead to a dampening of our spirit and ambitions and leading to mediocre results. We start accepting less. It is a good example is our standard of when an aneurysm is treated is when we say it has been near complete occlusion, while we should always aspire to complete occlusion. So this pushes us and the young population to a passive mind approach, which is to consume information regurgitated in a familiar form. This is, I am lucky to have teachers who have been pioneers and they have a creative mind. It's active, transforming everything it digests into something new and original, and creating instead of consuming. Now, why I say all this? Because after so many discussions with Professor Yazagil, looking at how himself and other of my teachers exercised their courage to push something like the cavernous sinus, which Vinco pioneered, it led to me to a key moment where more than 20 years ago, I made a choice, decided to forge my own route with the basilar aneurysm. Now, that has a challenge with it, and you have to empower yourself to fight because it was a fight. This was one course that others will see as unconventional, and because the endovascular approach became more prevalent, so I had to block this from my mind to focus on the fact that it suits my patient needs best. And it came harmonious with my experience and knowledge in and around the cavernous sinus. This with equipped with Yazergil's always mentioning in our discussions, nothing is impossible. And I extracted from this more self-confidence and self-awareness so that we can attain our goal in doing this. So I owe everything I say to great teachers that I have experienced uh, vascular surgery with, and I use their experience to lead me. And we're all under the umbrella of the microsurgery of Professor Yazagil. So I'm really one of the very lucky young neurosurgeons when I finished and I happened to land where Al Mafti was. I was supposed to spend a year with him, and then he invited, and Professor Yazagil joined us, and we spent a beautiful time together, more than 15, 16 years. So, and going to what we do with the aneurysms, and Vinko eloquently in his lecture mentioned all these pearls. And it is true, aneurysm surgery should not be brain surgery. It is subarachnoid surgery. If you're doing brain surgery or aneurysm surgery, you're doing the wrong thing. And clipping aneurysm is not a step, as you see in Professor Yazagil's videos, and when you watch him, it's a process. If you don't approach aneurysms like this, you're going to leave aneurysm behind and you're going to damage the brain. And that's what actually made us shied away. And as Vinko mentioned, we have to be able to go in and out, and the brain doesn't notice that we were there. And like a commando operation, you land in the middle of the night to the right house, and you leave in the morning, nobody knows that you were there. So with the basilar, why I still doing them? This is a good example. This is a case referred to me with one of my fellows. A 35-year-old, subarachnoid hemorrhage 2011, coiled, recoiled, 2017, come back, and now they couldn't do anything about it, what to do about it. So at the same time in Little Rock, this is the case how it looked. This is a beautiful, easy case to clip nowadays with the right exposure. So going back at the same time in Little Rock, when it was sent, I had this case which presented to me. And this is a curable problem. So in this case, what we did is the approach, which is like a variant of the transcavernous approach, which is centered around using the temporal side of the middle fossa and using this exposure, which was, pioneered Vinko. And the whole opening is coming in this region to where you can open, skeletonize the third nerve all the way from the brainstem to the superior orbital fissure. You create a huge pretemporal route and then open the sylvian fissure, remove the clinoid in this case because posterior clinoid to get access to the basilar trunk, and then use the trick Yazergil introduced, which is to cut the PCOM at a perforator-free zone, and then you have a majestic view of the aneurysm. If you notice on the left side, there is a clip. Down here, there is a clip. There is a temporary clip on the basilar trunk and the P1 on the opposite side, and you have full view circumferential with the perforators and everything looking in front of you. And if you look at the actual surgery, the view is, you can see all around it 360 degrees. And Vink mentioned it beautifully. The aneurysm has to be exposed. When it's not exposed, it is dangerous. Once it's exposed, the clipping part is the easiest part. And that's when we have everything visualized circumferentially. And then you can see now this is coagulating and shrinking the aneurysm. And now putting the clip is, like he said, you can get somebody from the street of course, and it's exaggeration, but the point is it's the easiest part. Well, the exposure is what made this the most important, steps to get to it. So this is what we achieved. The same result, unfortunately, in the other 35 years old was not achieved, while this was about 50 years old and this aneurysm is cured. So how did this aneurysm look? This is what it looked. And if you look at the literature, it does admit, this is a review on apex aneurysm, a meta-analysis, that microsurgery is complete occlusion 90 and lowest rates of rehemorrhage and retreatment. So we know that aneurysm clipping is superior, but unfortunately, the term which is stopping us is when it says it's most morbid treatment, which is, I think it is as morbid as you do it. It is not a morbid treatment. It's an operation which, if you're done properly, and God bless Evandro in the heavens. I quote him always. When is surgery a superior option? His words, when done at a superior level. And that's really the good answer for this, because we know from our analysis that it is the best option, the best treatment. Why not use it? Otherwise, here's what we will end up. These are the cases I get. Stent, coil, and now you have a tumor in the brainstem. This is a malignant problem now. Look at the case, this one. This is the hypothalamus gave this patient dementia. Look at this one. I begged my fellow who sent me these pictures, don't let them coil it. What did it end up with? A massive stroke in the brainstem and a locked-in syndrome. We cannot just assume that we're failing. Look, this is so many articles published about how to deal with endovascular failure and the causes. And none of these articles says a word about possibility options with microsurgery. So what did we end up doing? Like Michelangelo mentioned, the greater danger for most of us lies not in setting our aim too high and falling short, but in setting our aim too low and achieving our goal. This is important to avoid, really. So when is endovascular inferior? There's a lot of example. Dr. Kato mentioned it, the basilar, the giant aneurysms, basilar, aneurysm with mass effect, aneurysm with large neck, and hemodynamic stress location. They tend to recur. And basilar fits all this. And these are the examples. This is a classic case to fail endovascular therapy. You can reconstruct it with the right approach and the right exposure. Another example, another example, another example, another example, and many examples. So I'll show cases which go in the spectrum of all this. This is a wide base with, as you notice, there is a very bulging part, and then with the exposure is done, either you can see almost copying Vinco's pictures and going down to this area and exposing the pretemporal space, and then exposing the region of the cavernous sinus, opening the sylvian fissure as described by Yazergil from inside to outside, and then going down to the region of the interpeduncular fossa. And you can see the exposure that we get as we skeletonize the third nerve and widen the space. This is the PCOM being removed. The PCOM removal allows you to see behind the aneurysm. And then as these steps are being done, you can see gradually you get a full view of the whole complex. And eventually you get the basilar and the perforator free zone. And then that's when you put your clip and you have full control of the hemodynamics at this level. Then you become a safe clipping process. And this is a P1 on the opposite side. And then you have the application of the clip becomes much easier to be achieved. And by the time we finish, we're collapsing the aneurysm. You can see behind it and in front of it. And you can see the whole complex after you finish with 360 visualization, again, the clipping part becomes the easy step once this is the case. And the beauty of it is all this is being done under the brain in the subarachnoid space, where these patients can go home within 2 to 3 days. Now, we go, and this is the, and you can see this is the, after the closure, the opening of the dura is way under the brain. This is the opening of the dura. We don't see the brain much. This is a larger one, which is a case that is ruptured. And the advantage in this case is you don't have to deal with the swollen brain. Again, this is a typical aneurysm that will fail endovascular treatment. You can see the wide base, and we'll cut down to the exposure, and you can see the next thing is we're looking at the aneurysm, and you can see here, this is the posterior cerebral, the aneurysm, and the view after putting the clip on the basilar artery, you can see the view, you can see the opposite P1 because we removed the posterior clinoid completely, and this is the lateral P1. And you can see all around it. That's the big advantage is you create a highway that will create no more blind spots. And then the process of clipping start. Professor Yazigil, we coined together this is called the pilot clip, which is the first permanent clip, but it's not permanently applied. And then we collapse the aneurysm. And then the next thing is to apply a clip which is has more vision, because now you have a smaller aneurysm, and you apply the clip, and then you can take the first clip because maybe it wasn't the perfect clip, and now you have an unruptured small aneurysm. You can look around, dissect, and then put your last perfect clip, and you can see a perforator. You'll see it in a second, which is just adjacent to the neck. But now you have the perfect clip. But look at the view, 360 degrees, and this is the perforator behind it. And now and then when you do your ICG, you can visualize the whole complex, and nothing is hiding from you. And you never go home without knowing that you have preserved every single vessel. We go to, and this is how you can see the view on both sides. Again, the surgery is all done under the brain. Even like this aneurysm, posteriorly projecting, digging inside the brain stem in the interpeduncular fossa. And I will skip the approach. And this is the opening of the fissure, the same thing. And this is, I'm just making a point here. This was a very difficult fissure, but these steps have to be done with the winning mentality. You don't want to be frustrated with any step of the operation. You have to just see the course and do the whole work with the same approach, same thinking. So this is the third nerve dissected all the way to the brainstem, because this aneurysm was digging into the interpeduncular fossa, like you see it here. This is P1 up there, P1 up there, and this is projecting posteriorly. But still, once we put the clips, this is a clip on PCOM on this side and the clip on the basilar, you can see the anatomy now. This is the perforator behind it. This is the proximal part of the neck. And the rest of it is collapsing aneurysm, sometimes coagulating it, which is a powerful tool. And I think Dr. Toure was going to talk later about it, that Professor Yazigil introduced. And then putting the clips with the right exposure, then you can see both sides of the aneurysm. And then the clipping part, even in this complex one, becomes easier. You can see I put a cottonoid behind so that I can push the perforators away. And then by the time we finish, we collapse the aneurysm, and then you can look around it and dissect and make sure that it's completely clipped. Even larger ones, these are in Sugita's book. He showed a case like this, which was considered non-clippable, and understandably because of how big the aneurysm and how wide. But again, the real money here is in the aneurysm neck. The exposure is similar. I will just go fast to show you the view we get. This is the view we get. after putting 3 clips, one on P2, on P1, and on the opposite P1. And now we have a full view of the aneurysm. This has a posterior bulge. And now you can see the posterior bulge in this area. And that's how the aneurysm looks. Now, this aneurysm is not possible to clip unless you have space, unless you deal with it as a process. So we have to collapse it, and you have to stage your clipping. And I will show you a little picture. You have to collapse the neck, because if you want to clip it once and for all, it's not possible. So we put the first clip to compress the whole system, then you sneak in the second clip, and then you take the first clip out, and then you can achieve a full control of it. And that's how the final view looks once we finish the clipping process. We take another one. This is a very low, behind the basilar, behind the basilar trunk almost level. And in this case, you have to do the full transcavernous approach. In this case, we open the Meckel's cave and mobilize the 4th nerve all the way out of the way. And this is nowadays this is a 6th nerve carotid. You identify the anatomy. This is an exercise in the lab, exactly like what you do in the lab, except you do apply it in surgery. And notice there is no brain seen. We're working way subtemporal in a way. Now we're removing the petroclival bone and the dura. And then at this stage, the aneurysm becomes fully visualized. This was an extremely low aneurysm. And you can see the view that you get. The clipping part of this aneurysm becomes the easier part. Once the exposure is done, I am applying my clips under full vision, being able to see both anterior and posterior. And I have a lot of space. And again, you know, this was really, I was pushed by Professor Yazagil to keep doing those aneurysms, because I remember very well, he said, this is progress. This is where we need to be. This is what he expected us to be 40 years later. And you can see now the view is seen on both sides, now collapsing the aneurysm. You can see it on top of it. And then the next thing is you will see the ICG will show that everything behind it is all filling. So now this is a very large aneurysm, which is quite complex in shape. And to make it worse, look how low it is. It is way down on the clivus. This again was approached in the same way. This is starting from the fossa. The 4th nerve is skeletonized. We identify the carotid and the petroclival ligament, then I know everything behind it is safe because the 6th nerve anterior to it. And then we skeletonize the 4th all the way and get it out of the petroclival space, and by skeletonizing the 3rd nerve as well. And again, this is not traumatic. If you know how to dissect these nerves, sharp dissection in a tangential way along the course of the nerve, you are mobilizing them, that's all. They may have temporary problems within most patients, 4 to 6 weeks, it's completely recovered. But this is a small price for curing a problem like this. This is Meckel's cave being open, and now you can see the space into the posterior fossa is a majestic view. The basilar starts showing up. Now the opposite P1, because this is very low, has to be visualized, and I'm removing almost the clivus and the posterior clinoid. Now posterior communicating is cut, and then this large, deep, very low aneurysms start becoming visualized and being seen. And you can see I'm looking now on the opposite side. I need to get more space, so I will take a little bit of the bone further, and then I can see P1. So I will never attack, you see the 3rd nerve and the P1. You never attack it. You have much more space to create. By now, the whole space is open. This is P1 with basilar, and then by the time I put the clip, it is the much easier step. The first clip is applied, and then the other P1 is seen, and then all this is done under the brain, and those are the perforators behind the aneurysm. Now the aneurysm is being completely clipped. However, the beauty here is you can see everything around it. So in this case, it has a posterior bulge, and if you leave it, it will leave residual behind it. So as we removed the clip from the basilar, now I realized there is this bulge posterior to it, and then you will see it in a second. And this is the bulge here, a residual. So then we will apply another curved clip. This is the curved clip coming down into the residual included. So you will, this is the biggest advantage is 360 view into the aneurysm, so that when you finish, there is nothing of the aneurysm left and it's all completely clipped. And again, all this surgery is done under the brain, away from any of the perforators. And you can see the view after we finish, and you don't mind anything regarding the swollen brain. I'll show this last case. This is a basilar trunk which could not be clipped, and this is a fenestration, I mean, could not be treated endovascularly. You can see the aneurysm projecting. Actually, there's an aneurysm in the posterior part as well, and it had the fenestrations. The steps are similar in this case, and you can see in a second the big advantage you get with the transcavernous approach. These are the steps of finding the anatomy. This is the carotid in the cavernous sinus. And once you get the carotid out of the way, and this is the sixth nerve, you know, everything posterior and medial to it is safe. The next thing is to mobilize the fourth nerve, because you want to open the whole tentorium up. That's the fourth nerve intradural here. And then the next thing is to unlock the fourth nerve from its space and then mobilize it out of there. Then following it, again, this is all done in the lab, and this is an exercise from the lab. And this is the steps, and you can see the fourth nerve completely mobilized. And now we will get it out of its gutter. And now we're opening all the dura, medial and lateral, to this third and fourth complex. This is the third and fourth are pushed aside. We know this is safe because it's behind the carotid, and then you start working on furthering the exposure. This is opening Meckel's cave, and this is the rootlets and the Gasserian ganglions anterior. All this space is just dura. It's safe to remove. So once we get this and open this space, you will take the petroclival dura, and now look, you can see the view that we get to the aneurysm. Now the clipping part becomes the easy part, like Vinko said. It is the exposure that makes the difference. Now we can take the clip, and the aneurysm is in front of us. It is ready. It's almost asking, why did it take you so long? And then there is an aneurysm behind it that you can see. And again, the clipping part becomes the easy part. And the rest of it is the same with the posterior part. Now, this aneurysm wasn't possible to be treated endovascularly, and especially the posterior small blister that you see. And this patient has an ictal episode. She had an acute bad headache, which we were not sure if it ruptured or not. So you cannot leave it without removing this. And again, the advantage here is, look at the approach. It's all under brain. So our experience now is close to 190 aneurysms treated with one variant of the pretemporal approach. We have 3 regrowth and unclippable 3, but 2 were reclipped, and one of those was coiled. The oculomotor palsy, almost 100% now will recover. We have 2 patients who needed prism glasses, and this is the results. The ruptured ones, they have great outcomes, even in those cases, because the surgery is all done under the brain. 80% in a year are in good shape, sorry. The unruptured ones, within a year, 98% of these patients are in great shape. The the 99% in 1 year. Those we had results, and I always tell people who doubt that basilar aneurysm can be treated, please come to Little Rock, see the surgery, and see the patients. Now, it is a must that we continue progressing with microsurgery because number one, it's needed. Number two, it has unlimited potentials. And this is when something is mastered, it looks simple, like Finko has shown and Professor Yazagil. These are the words of Yazagil. Nothing is impossible. And for the young generation, I always like to say, know your limits. Don't jump prematurely, but have no limits. Always push the horizon of what you can do. And I want to quote Evandro's criteria for success: have the passion, determination, and courage, and an inner sense, which a lot of these pioneers have together. And this is what Professor Yazagil presented in the last WFNS: judicious courage, which means be courageous, but don't be reckless, and based on professional competence. And that will lead us to more. This is our courses that we have done. And I want to assure Professor Yazagil that microsurgery is really way more alive in young people than a lot of the wrong statements that being said that microsurgery is dead. This is our last cavernous sinus course. It's heavily, and hopefully soon after this COVID problem, we will be able to come back. So again, thank you, Ahmad, and Professor Kanaan and Professor Benich for putting this together. Outstanding speakers, and honored to be part of it.